So yeah, Dr. Arjun Devarajan. So Sir is the section head of medical service and senior palliative care physician at Pallium India with a focus on integrating specialist palliative care into health system and completed certificate course in pain and palliative medicine, national fellowship in palliative medicine and a fellowship in compassionate leadership with IAPC international collaborators, actively involved as a faculty in palliative care education program both online and on-site to build capacity among healthcare professionals and awarded the prestigious David Gold Medal in 2022 for his contribution to palliative care. Currently part of the Singapore-India Pact program strengthening the international collaboration in palliative care. Sir, welcome or sir, over to you, sir.
Thank you, thank you. Very warm good morning, everyone. And thank you for the warm welcome. So today, welcome to the day, and today's session is on the very important thing, the end of life care. So, what is the importance of end of life care? This is a situation when we address the whole person need at this time with excellent clinical skills, compassion, and understanding. Because this is where the patient and the family, the caregivers, everyone is at the most vulnerable stage. They are at the most difficult phase anyone can face at the during their life. Like their loved one, the person is nearing end of life, or their loved one is nearing end of life. So this is a situation that normally we should that we cannot approach as in a normal healthcare professional. Like we need to be with excellent clinical skills to reduce the suffering. The patient might be in severe suffering and very much compassion because they are going through the worst part of their time and understanding. They might be anger. They might be severe sad. You can see a large blast of their emotions, and this might be the time you might face multiple issues, and you should be trained enough to manage that. Why do we need that? Because we need to reduce the suffering, maintain the dignity and autonomy. Dignity is very important, especially in such thing, because we as palliative care professionals, we are the best persons to provide a dignity, right? So the person might be in severely pain, or he might be in severe delirium, which is very evident that in stages, and maybe maybe vomiting, severely vomiting, very pretty bad stage, which is not responding to normal medications. So that is a time where we can provide a death with dignity, as we call it. So we have a practice we call as death with dignity. It's an every person is entitled to die with dignity, free of symptoms, free of distress, and along with their family members. So our goal of care would be minimize distress by meticulous symptom control and supportive care while maintaining well-being and moral integrity. So ethically, we are imperative to provide adequate relief to suffering. Any suffering we are supposed to reduce. As ICMR says, we may not be able to cure always. We may be able to control symptoms, but provide reduce suffering is it should be the aim of each and every healthcare professional. And dying person should not be subjected to any inefficient treatment which might cause further distress. So there might be multiple points like options which might lay ahead to hold on to the life of the family, that which we usually practice. Like consider a very person with advanced carcinoma lung coming to you. Maybe he's very breathless, very advanced situation, elderly person. Consider a 75-year-old stage 4 carcinoma lung patient come with severe breathlessness, maybe pulmonary edema or pleural effusion, or something which is causing very much distress, not responding to medication. The next point we will be having the normal hospital would be shift him to an intensive care unit maybe even go for a ventilation. We support artificial ventilation. So that's what we usually do. What we want to do is like try to keep it, hold him to that, like how much time, whatever, let us prolong his life. We don't want him to die in our hand. So we'll do everything we can. But what beneficence does it lead to? Like if put this patient on intensive care unit, what are we expecting to? We are not going to cure the disease or improve the quality of his life. Even if you manage the symptom immediately or put him on ventilator, it's just that symptom might get controlled, or what else is he will live for another day. But what about this added day that you have helped him to get? Will he be having a quality of life? He will be in the support of the artificial ventilator, away from his family. Like we may not be like letting the family to be with him, or nothing happen. So that isn't that like we are not improving quality of life. So do we need such interventions? Is the question we have. See, every patient has a right to adequate relief of physical and psychological symptoms and social supports. So if the patient wishes to be spending last moment of his life at home with his family, the loved ones, his children, the grandchildren at bedside, we are supposed to help him get that. The symptoms might be there. We are supposed to help them symptom reduce the symptom and do as much as possible to get his dignified death according to him. So patient has a right to care that enables them to have the best possible life given constraints of the prevailing conditions. Yes, there might be issues, but the best thing, whatever best thing we can provide should be assured for them. So what is the terminal phase? So before going that, like I would like to know if any of you have an experience in your own personal life or someone you very close to know going through the terminal phase, seeing their end of life situation. Can anyone unmute yourself and speak? Anyone with an experience? Did anyone of you have an experience in your life? Maybe it's someone you might have cared for your patient, some end of life event that you cannot forget. Kindly like don't take this as our lecture sessions. Like this will only help if we interact each other. So this is an opportunity to learn each other. Like I don't know much things. You might be able to teach me things much better. So please feel free to speak up. Don't worry if being wrong. I might be wrong. You might be wrong. Everyone might be wrong. It's a chance to get us corrected.
Vinod Kumar. Akansha. Okay. Akansha, please respond. Richa Sharma.
Yes, ma'am.
Please respond the question.
Ma'am, sir, can you just repeat the question?
Like just I want to know if you have any experience that you would like to share regarding an end of life patient or someone dear to you or someone you cared for, some patients or anything, an end of life event that you have gone through.
So actually, I'm not working in a hospital area. I'm working in a community area, and we are doing a visit for the old patients having some old age related complications in the community area. So I don't have that much experience. Like end of, I haven't seen that, but we are visiting the people in the community area. We are doing the assessments accordingly, and through all the sessions through Pallium India, all that what we have learned till now through all the sessions, we are trying our best to deliver the services that we have learned.
Great, Risha. Thank you. But no, you are very much experienced. You have been working in the community. I'm not asking about the palliative care services or what you are doing. I just want to know, have you seen a patient dying or who's nearly dying? So you have been seeing very elderly persons in your community. So how? I just want to know any experience that you have.
So, not now. When I was doing my degree, my own grandmother, she was terminally ill, and she was a cancer patient. Although I have seen her, like she suffered literally, and I have very vague memories for that. Not that very clear much, but I have seen her suffering and the care, and she wanted everything just to provide the care at the only home based. She don't want to be hospitalized. So I have seen that we have provided certain care through the caretaker, but so that's my kind of experience, that I have seen my grandmother in that stage.
Thank you,
So,
Richa, for sharing that. So
yeah,
this is, and understand this is a very painful situation like to
yeah,
share.
okay.
Do we have specialized? So
So,
this is something.
Someone is sharing their experience in chat box, sir.
Okay. So yes, when patient is being to you had experienced such a situation. Joan Bhutia, so could you kindly explain what it was, Mr. Bhutia?
Actually, sir, I have worked in intensive care unit. So in those days, like I have experienced so many patients who cannot be recovered, like they are declared brain dead or such situation. So I've experienced such thing. Like I have given care for those patients. Like there's no chance of uh, reviving. I mean, coming back to the normal states. So we have uh, given them a care till their last breath.
Great work. So, can I ask you, do you think something was missing there, or something we could have improved there? You have worked in the intensive care unit. Unfortunately, a large number of people and get to the end of life in intensive care unit. You and someone who was nearby a dying patient. To many dying patients at the last time. So, do you think something we could have improved there?
sir, I want to share
Please.
that through all these sessions, we have come to know the holistic approach, the comprehensive approach, like physical, mental, social, spiritual, that we have to collaborate all the factors. And after the death of the person, there is that bereavement phase that also we have to follow. It's not that if the patient is dead, it's over, everything is over. No, after that, it's an ongoing process. So through what we have learned through all these session is that holistic approach is must, that we have to go through the holistic approach, including all the dimensions: physical, social, spiritual, psychological. And after the death of the loved one or anything, there is a bereavement phase that we have to comfort, and the family, the caretaker, it's not only about the patient, that we have to include the family members also in that. So it's overall a holistic approach for everything.
Great. Thank you. Thank you. This is what we aim from this session. Like there may be people suffering in the whole life and they might be right in front of you. If we can provide the best care,
Yes, sir.
considering the psychological, social, and spiritual issues, that's the best thing we might be able to provide to someone in their suffering. I hope we all can work together in that. And let me just share one more thing. I will say a story. Sorry. with respect to this situation, um, so see this, I will just tell the story of two persons. Okay, this is Mr. A. He's a 93-year-old male. He was a long-term diabetic. He suffered from a stroke 10 years ago. He was wheelchair bound and aphasic. He was not able to speak properly. He had also had advanced dementia and unable to recognize anyone. He had declining oral intake, recurrent hospitalization for respiratory infections. And June 11, he was admitted in intensive care unit with septic shock, urinary tract infection, AKI, CKD pneumonia. He died on August 15 while on full support. He was in an intensive care unit from June to August. Okay. Now there is another person. He's 94-year-old male. He also had vascular Parkinson's since 8 years, very old, frail. He also had speech limitations. Mobility was restricted. ADLs were dependent. Recurrent hospitalizations were required. And at a point, he decided no more hospital visits. He would stay at home. Luckily, he had some. He was able to afford a home care team which was supporting his needs at home. But the thing is, he had been regular visits from his friends, old colleagues. He was a very big professional, and he spent his most time in his own bedroom. His children, grandchildren, old friends were visiting him. People used to, his friends come together, they sang besides him. And like one of his last word was, I love you too, to his son. And the son replied, he was a good dad and he loved him. So one of his friends who was nearby the bed, who saw this end of life event, his dad said the death was peaceful. And if some those things that like the death could be sweet, this was sweet. This is how they explained about his event. So this is a question: who had good death according to you, Mr. A or Mr. B? According to you, who do you think had a good death? The first person was both had similar case histories. First person spent his end of life last 3 months in an intensive care unit away from everyone, but getting good intensive care on full support. He was. Second person didn't get that much. He was at his home. Mr. B. Mr. Sagar has said Mr. B. Why do you think Mr. B had the good death? Okay, more getting answers from Mr. B. So why do you think B had a good death? A also received good support, medical support. He was on intensive care unit, full support. He shared last moments with his family members. Yes, that's a good answer. Good one. Good option. Does anyone contradict? Anyone think A had a good death? So moving forward, like these two really happened. This A and B are original people. Okay, people you might be knowing. Can anyone guess who they are? Mr. A was Atal Bihari Vajpayee, the former Prime Minister of our country. Mr. B was George Bush Sr., the former President of the United States and father of the George Bush Jr. He was also a former US President. So I'm just mentioning two situations. Similar situations has happened again. Like one of our the renowned singer, Lata Mangeshkar. She also had to undergo intensive care unit admission for the end of life. She was also placed in endotracheal tube. Likewise, the former the Queen, the monarch of UK, the former Queen, she didn't want any aggressive management, and she also received a good that at her own home without any aggressive treatment. So coming back, so terminal phase is a period of irreversible decline in functional status prior to death. It might last few days, few hours, 2 days, and very occasionally it can go up to weeks. So, as Isima said, our aim is to mitigate suffering. It is to cure sometimes, live often, and comfort always. Always comfort. That is there is no exception to this rule. So, assessing and prognostication. This means recognizing that a patient is immediately dying. So, we are all healthcare providers, and we need to identify the patient if he's immediately dying. Why? Because we need to provide the patient and the family with information. So to what to expect and that meaningful goals, priorities, expectations of care. So many often these issues, the fights with the families always happen. Many often because of the lack of a proper communication. Sometimes there are situations we cannot prevent also, but many could be reduced to an extent if we could be able to provide communication well. So this is a situation where if the patient is near ending and the family and even the patient gets the information what is to expect, they can set goals what they can. They might not ask you for an aggressive management or something intervention that need not benefit from, or like if they wanted to set something like writing a we call that like a bucket list if they have a bucket list, or getting their business done. That's what we call. So, like writing a will, or ending enmity with a friend or relative, going to some places, eating a sweet. There could be multiple wishes they have before their end of life. So they can go for that. If we didn't explain to that, they didn't have the escape, they might not be able to get this done. One of my patients, I remember, she wanted to see her son's marriage. So she was nearing end of life. She was on continuous infusion of morphine and haloperidol. That was for the bowel obstruction. And she wanted to see the son's marriage, which was planned 2 months before. So we did talk with the family and we preponed the wedding to a week after. And the beautician came to our inpatient department. She was dressed in colorful saris, silk saris, and she was they made her makeup done to her in our hospice, and she went with the continuous infusion. We put her on continuous infusion. She went there. She attended the marriage. She had little parcel, a sweet we call, and she came back to the IP. She was very happy, and she passed away a week after. So we were able to get her biggest wish done because we had a serious discussion with the patient and the family. So likewise, this is also important for many clinical decisions. Like a patient with an advanced cancer, not taking or reducing the oral intake is normal because of the situation. But we forcing a rice tube inside and force feeding him is not going to benefit him. Only thing is and prolong his life and increases the risk of aspiration pneumonia. So such person, if we can communicate well, that is end of life. The family and help us with the clinical decision. So prognostication, like identifying the death, we have 3 steps, mainly formulating the prognosis. So identifying what the prognosis is, communicating, and using prognosis and taking decisions, as we already discussed. So there are 2 ways we can formulate the prognosis. One is a clinical prediction. Like that's our own prediction. So we call a situation called a surprise question. This is a question like, will you be surprised to see this patient after 6 months? So this is the question. This is the only thing that we ask for prognostication. Will you be surprised to see this patient after 6 months? So this is a question the treating person asks himself. If I am the treating person, I ask myself, will I be surprised to see this patient alive after 6 months? If I say yes, I'll be surprised, then this patient can be considered as end of life. So here, my subjective judgment is because I have been cared for him or I know this history, I understand this patient might die within 6 months. So we can consider this patient as an end of life patient. So this is called a surprise question. Second option is we go through the data like studies, like 5 years survival rate, how long will we be. So first thing is most commonly and most easily used across the world. So say few symptoms which indicative of entering terminal phase. There's a study which happened with us and check. Um, Progressive weight loss with sudden loss, profound weakness and fatigue, which is not responding to anything, social withdrawal, disinterest in food and drink without any symptoms or any causating factors, progressive dysphagia and difficulty in swallowing even medication, refractory delirium, which we cannot know what is causing. There won't be any defined cause, and it might not respond to medications. It becomes refractory. Changes in breathing pattern, the kind of breathing or breathing patterns, labored breathing, the mouth breathing, accessory muscles involvement, all those could indicate. And drowsy for extended period despite much. He was not drowsy with the medication, even with medications before, but now he's becoming more drowsy. Reduced urine output, that is one early indicator. And the skin becomes very cool to touch and very waxy. So these are few things which are indicative of an approaching the terminal phase. So now we have identified this patient is approaching end of life. What we do next is we communicate with the patient and family. So what is the things, concerns like prevent us from talking this? The family might be saying, like they might be entering the patient's emotional distress will increase. He might go into a cardiac heart attack or something if he's feeling this. Please don't tell this to him. There is reduced number of aggressive medical interventions near death, and compared to those who had not these conversions, there is reduced distress and improved quality of life for both patient and the caregiver if we had a good communication with the family. So these are based on studies which happen. I have quoted them. If you want, please read those. So there is reduced number of interventions, better reduced distress and improved quality of life if you are communicated. And these communications are not associated in increase patient emotional distress or psychiatric disorders, and reduction in family of bereavement. Like ma'am has already mentioned, palliative care does not end with the time. It continues even through the bereavement period. So even after every loss, the families go through a very difficult time. And earlier communication is said to reduce the distress during this bereavement period and have better time for coping up for the loved ones. So early communication is very much needed. So this, maintain a balance between supporting the patient's and family sense of control and dignity, reducing their fear of suffering, maintaining hope for good quality of living whilst preparing to die. So many their families will be against his support, aggressive man, want to do aggressive management. This fear of going into distress. Ensure them that they know via palliative care, through palliative care, we can reduce the distress and we can do whatever we can to reduce the suffering and have a good and dignified death for the patient. So what are the main things we need to do? Information and communication, evaluation of the family needs and resources. They need what are the resources they have and what we can do. Also educate them on the care the patient is going through, pretty bad stage and symptoms might be worse. So we need to educate the family on it. Like there will be reduced food intake. Patient have dysphagia, swallowing difficulty might worsen. So what we can do, we will have to go switch to semi-solid food. Rather than giving big meals, we can give small amounts of feed at different times. Crisis management. This patient can go to a death event or worsen situation anytime. So we might need to educate the family on how to manage. Like a patient with a large fungating ulcer, what if it bleeds out? He might die without knowing. The family will panic. So we might have to train them what to do in such a situation. Put dark colored clothes, apply over there, um, or do some medication if they have in hand. So what is supposed to do? Not panic. Or if it is a breathless episode, what we can give them a shot of morphine, which they have already given. So such crisis management should also be educated. And review for the family copy. The family, they are the loved ones, so they might might not easily digest what you have said to them. So we need to review them, make them prepared, keep talking to them, and even when the care of the family should, when patient is unconscious, prepare the family for the dying process. So advanced care planning for patients and anticipated threatening events, the withholding, withdrawal, and non-escalation. So withholding and life-supporting treatment, preventing from starting. So the patient gets worse. Maybe the person we talked earlier, like advanced cancer patient comes with breathlessness. So should we be shifting into ventilatory support? That's an life-sustaining treatment. So we can withhold them if it is not beneficial for him. So that's called a withhold. And already a patient on ventilator, which is not doing any good, only adding on to suffering, we remove the ventilator, it's called as a withdrawal. And non-escalation also, so we think about like patient on maybe he was a non-invasive BiPAP or CPAP, non-invasive ventilator, but it is not supporting well. He needs, his condition is deteriorating. Ideal choice would be shifting to a ventilator, but not escalating that to that based on the situation of the patient is not. So what are the things we have to do in an end-of-life situation? One thing is discontinuation of non-essential medications. He might be having 100 medications in his hand, a handful of tablets he eats each time, day, morning, night, I think. So identify and seize any drugs which does not contribute to patient immediate comfort. This patient might have a few hours or days left. Should we continue this medication would be a question. Like a patient after the CVA or cardiac event, he might be put on atorvastatin, which is ideally to prevent a future event. But a patient nearing end of life, he might have a few hours or day left. Do we need to continue atorvastatin? There is no point in continuing. Maybe an echospin also. What we are expecting is preventing is an MI or a stroke event, but he has only few hours before. So discontinue any medication which does not contribute to the patient's immediate comfort. Multivitamin tablets, supplements, stop them all these things. They are not going to do any good for them, only harm. Likewise, observation, investigations that do not contribute to comfort. See, a patient in dying, nearing end of life, very carcinoma lung or COPD patient nearing end of life, there is no point in continuous checking of ABG or constant concentration. We might not improve the concentration or correct the acidosis or something. He is going to die. What is the point of pricking and going through that? It's not just pricking the patient, the cost, the resources are being misutilized. So they might not be needed. So we can stop all this. And family needs reassurance that meticulous care continues with comfort being the goal of care. So the family might mistake that you are stopping all treatments. Tell them we are not stopping all. Meticulously, we will be continuing care with comfort of the patient is the goal of care, not prolonging the life of patient. Make sure patient paying for pain symptoms and pain management medications. He might be on pain morphine for the pain. Now his situation has improved. Do not stop those medications because that gives the patient more comfort. And we might have to change the route of administration because he is not able to take orally from oral to transdermal or parenteral. We suggest to use subcutaneous routes whenever possibly it is less traumatic. We don't have to think about the veins. Most of the medications we can administer through subcutaneous route, less painful. It does not bleed. We can educate the caregiver also to use that. We often train the patient's caregiver to do this at home. And loss of ability to swallow in the terminal phase should be anticipated and planned for PRN medications when indicating. Like a patient with some severe pain, we always have, there is a breakthrough pain, we'll have to teach them to take whichever medications they can to other rooms. Is someone trying to speak up? Or? Okay, so pain, do not discontinue analgesic in a dying patient. That's the worst thing we can do. Ensure availability of medications to be given by normal, non-oral route also. Like subcutaneous or parectly. If you are giving paracetamol, you can give parectly. Morphine can be given parectly. If it has a benzodiazepine, we can give lorazepam sublingually. So such route should be made aware. Hannah, so sorry. There was some disturbance. Is someone's mic on now? Okay, and review the clinical need for any medications for which there are no parenteral form available. Dyspnea or breathless. It's around 70% of the patient experience dyspnea in their last 6 weeks of life, and prevalence, severity, and distress increase as death approaches. It can be more of refractory. It could be by a tumor or general weakness and frailty conditions, chest wall disease. Multiple situations could be causing this refractory, which is not responding to normal medication. They might not respond to the steroids or the bronchodilators or something. That is a point where we might have to employ parenteral opioids, opioids, parenteral or oral medication, or morphine or fentanyl or something to reduce the distress of dyspnea. And benzodiazepines, which we do not usually keep hold of in breathlessness, may have to be introduced to reduce the panic and anxiety. Oxygen therapy is something we usually use, but many often it is very less effective in an end-stage patient. You can give a trial of 10 minutes. Give them a trial of 10 minutes. If the patient situation improves or the patient becomes comfortable, please continue. Otherwise, that indicates it is not going to improve, do any good for the patient. I am not mentioning about improving the saturation. I am asking you to consider the patient as a whole. You put oxygen for 10 minutes and the patient becomes more comfortable, continue. Or it doesn't reduce it. Sorry. If it doesn't cause any symptom relief, avoid. Oxygen is not going to do anything. But explain it to the family. Also employ non-pharmacological measures for breathlessness, like handheld fan, keeping them breathing exercise, all those things might be helpful. Very much often, like in severe distress, if the patient is in terminal phase, not responding to medication, we might have to offer palliative sedation. Delirium is up to 88% of the patient. You can say delirium. It could be either hyperactive or hyperactive. The patient might be very aggressive or very silent. He will be silently staring at someplace he is trying to hold on to something. He acts like, or like holding on to the bed sheets. He's trying to pick the bed sheet with his hand. So those indicative of hyperactive delirium. Or he might be very aggressive, not very irritated, trying to get up from the bed, trying to jump out of the bed. So those called as a hyperactive delirium. So it could, either of those could be seen in around 88% of the people in end of life. The most worst thing is it's more upsetting to the family and caregivers, and also us healthcare professionals who are caring for them. And delirium, end-stage refractory delirium is a very poor prognostic indicator. And what we usually do for a end-stage delirium patient would be trying to identify the cause of delirium, but not here. The patient might have less few hours or days to live. The key issues like symptomatically manage be the best option rather than finding cause of delirium. We may not be able to correct those. So we use medications like antipsychotics, the haloperidol, risperidone, olanzapine, which are available sublingual, and chlorpromazine we can give rectally. And benzodiazepines may be needed in delirium. Delirium was also an indication for palliative sedation if it is not responding to it. This is another thing we commonly see, the death rattle or thermal secretion. During last days of the life, this becomes very evident. You can see the gurgling sound, something a fluid stuck on his throat, the patient breathing through it. The gurgling sounds is we call as a death rattle. We do not know the mechanism, but it could be we're pulling of the saliva and secretions in upper airway because of reduced saline and dysphagia and the ability to expectorate. This is a very strong predictor of an approaching death. The patient might die within 48 hours. This thing is very distressing to the family or bystanders, caregivers who are nearby. But the thing is, this is not something distressing to the patient. The patient might not know this, but this sound is something which panics the family that this is causing distress to the patient. So we intervene here mainly to help the caregivers. Tell them this is not causing a distress to the patient. We can start with sideline position, trying to drain it manually. If it comes out, we can drain it. Do not do suction. Suction is an invasive procedure. It's painful. It is very unfortunate or very cruel to do such a painful procedure in a dying patient. We can use antimuscarinic agents to reduce the secretions like atropine or glycopyrrolate. These things are common. Glycopyrrolate is very commonly used because it doesn't cause a blood-brain barrier, because the CNS actions of those antimuscarinic drugs. So glycopyrrolate can be given sublingually, orally, submucosally, subcutaneously, or IV. We start at 0.2 0.2, can raise up to 1.2 or 24. We can even give us continuous infusions if needed. To address the functional decline and increased need of assistance, this patient might need more assistance as time comes. We need to look into the mobility, skin, and mouth care. Do not forget these things. These are needed to be continued even through the end of life. The skin care and mouth care are very important. And bowel and bladder should also be looked for. We do not want the patient to be constipated or dysuric because approaching death. We need to give them a dignified death and time. So nutrition and hydration, this is something very much distressing to the family. In our situation, we all express our love by feeding. So patient becomes nearing end of life, they will be having reduced food intake. So the family becomes panicked. This is the first thing they will ask you. He's not taking anything. What are we supposed to do? They even will ask you to put a rice tube or IV fluid, please, and with the belief that that will improve everything. So as a patient's conscious level deteriorates, aspiration risk is higher, and the stress of benefit of oral intake with regard to aspiration need to be explored to the family. We explained it to the family, this is a normal process of dying, this is indicative of dying. Fortunately, the patient is in a stage where he will not experience the hunger. So he is not dying with of hunger, but he's not having no sensation of hunger. The body itself is shutting down, and this is indicating it does have an appetite. So need not force feeding. Force feeding can only worsen the situations. Here, the vomiting can get worsened, aspiration can happen. All those things should not be done. Ask them to feed at small breaks, at small quantities. Whatever the patient takes would be enough. Even at stages where they think nothing orally, we have to assure them. Excessive fluids, if we even have an IV fluids, excessive fluids, the body is in a stage where it's shutting down. Renal kidneys are shut down. That's why a reduced urine output comes. So adding more fluids will only increase situations like pulmonary edema or generalized edema, pleural. So these fluids in the body that can reduce, that can only increase the breathlessness or abdominal distension, all those things only. So that is not a point where IV fluids might be more harmful than these helpful. So, but this is our situation. In a real life situation, we might have to compromise. So what we can suggest is subcutaneous fluid administration, which happens very slowly. This is only to as a bargain to help the families to accept that And subcutaneous fluid, since it is very slow at the administered, it's less painful. It won't be causing much of the symptoms as compared to an IV fluid. So palliative sedation is an option of terminal phase if refractory suffering is present. So the importance, the thing is, this we do is when symptoms are not relieved by normal medication, and symptom is so worse, not responding to medication, but the patient is in severe distress, like pain, breathlessness, delirium. So though any symptom which is worsening a situation, but not responding to any current medications, we might have to sedate the patient. This is aimed not to kill, this only to make the patient comfortable, patient not knowing what the distress is. This might need to be continued till the death. So there are certain times we might need sedation only for some time, like a patient in severe pain requesting to sleep at night. So we can reduce sedation only through the night time. We usually start the midazolam or short-acting. Midazolam is one drug we use commonly. So we can start at night time, stop at 6 o'clock or 8 o'clock in the morning. Patient becomes awake and continues. But if distress is continuing throughout the day also, we might have to think of continuing. So this is only for refractory symptoms and reducing the suffering. Also, there could be all these things, and there could be very difficult end of case scenarios, like unanticipated sudden events, like a trauma patient. This is very difficult because they might not be prepared for, unlike an elderly or a patient with a chronic disease. Post-operative overwhelming sepsis is one another thing, or an acute potentially reversible disease, as well as a consider an appendicitis getting worse and patient dying. So this was a normally treatable situation usually, but the patient got them. So such situation, young patients, pediatric patients, the worst situations we face. So getting these end of life scenarios will be very difficult and very challenging for us. Or things said, we always forget one group of people who are facing these end of life events. Yourself, your colleagues, we all are facing end of life events. We might be seeing this, going through every day with this, and we might be in trouble. No one usually used to face it. Look out for yourself. Look out for your friends. How they are doing. Communicate with them. Care for your colleagues. We are all human beings. Are into emotions. We might get affected. I have experienced such severe situations when we had pediatric patients dying. Managing end of life situations of pediatric is very difficult for us. I've been not just pediatric, but I have seen the worst things. So we do regular sessions, communication sessions. We all sit together, discuss each other, our experience. We talk each other. If someone can't get through, we make sure they get into the needed psychological support or even psychiatrist when we need it. So look out for your colleagues. Thank you. That ends my session. So now we can offer any doubts or queries or discussions you want to do.
Dear participants, kindly ask your doubts. So, is it clear? So how's the sessions? So they are saying thank you, sir.
Thank you, everyone. Thank you, everyone.
Thank you, sir. Thank you for the insightful session. And please share the PPT with me, so I'll share.
Sure, please send me your email. I will share.
Yeah, sure.
So thank you all. Thank you very much. Thank you, Hannah.
Thank you, sir. So